Hi.
Hello, everybody. Welcome back to the podcast. We are joined by, we were saying podcast veteran, Amy Hare.
That's right.
And Daniel Robinson. Daniel, Amy, thank you for coming on.
Thanks for having me.
There
I'm
you
a
go.
novice.
That's it.
Yeah, no.
You broke the ice. We're now officially, we're officially going, we have the audio officially going down. You said you had a lot of questions. So
I do have a lot of questions. But my first question is, I'm going to let you guys introduce yourselves. We know who you are, but tell us where you're coming from and your areas of interest.
Okay. Yeah. So great to see you all again. It's always fun to have conversations. So I'm Amy Hare. I'm a neonatologist and neonatal nutrition researcher. I would say I'm known for my research in human milk and enteral nutrition. A lot of my research currently is focusing on growth failure babies. Why do some of our babies not grow? And I'm part of the NEC focus group here with CHNC, and I joined probably a handful of years ago. And I've just been amazed by the passion of the group, how much we've been able to accomplish, and the meeting's just kind of an extension of that. It's a large meeting. I've been impressed. A packed audience, I think I put on Twitter yesterday, or X. Excited to be here.
I still can't call it X.
Yeah, still have to say Twitter.
We did that a few times.
Yeah, I think people know what we're talking about.
Yeah.
Daniel.
Hi. Daniel Robinson. I am here from Chicago at Northwestern University, Lurie Children's Hospital. I'm in the Division of Neonatology as well. And I also spend my time thinking about nutrition for our infants in the NICU. I have the perspective of perinatal fatty acid metabolism. So not only do I think about what babies in the NICU are or are not getting in terms of the different types of fats, but also I've expanded that and think about what moms and birthing parents are consuming during pregnancy and how that might influence the babies, how that might influence milk composition, and how we should think about the big picture there. And
wow,
so
that is actually very interesting.
Very interesting. Yeah. So we were just talking about nutrition and how varied it is. And we're all, I think, in all of our individual units, really struggling with how to optimize nutrition. So let's start with the basics. Like, why is a feeding program or a feeding protocol important for units?
You want to go first?
I think a key aspect is whatever goals you have, and this extends outside of nutrition, you need a system to make sure that you're meeting those goals consistently or as consistently as possible. Usually there's, if you could say you had a standardized feeding guideline, is it going to be followed 100% of the time? Probably not, but the goal is to get consistency and then allow periodic monitoring of the effectiveness of that program. And so I think that's one summary consideration.
Yeah, I would totally agree. And I don't know if you guys heard, I've tried to advertise. We are hiring. Little shout out for Baylor College of Medicine, Texas Children's. We're growing.
It's a perfect opportunity.
But I say that because Dr. Reber mentioned we've hired 20 plus faculty. And so part of that is we need something standardized to make sure we're all trying to practice the same. And again, protocols don't apply to all babies, but at least we have a common goal and we're trying to agree upon a way to move forward so that we're not, constantly changing what we're doing. And so for a big place like mine, that's extra important as well. It's important, I think, in all units, but I've really seen the impact more recently with a lot of new faculty.
So I have a question that impacts our unit all the time. Maybe I disclosed too much about our own home unit. But, we have a pretty good system. I think we're in line with most of the country in advancing feeds. But we really struggle with these babies who fall off protocol. And maybe you guys can spend some time telling us about what we should do with that group of babies.
Yeah. You can go first.
Just as we're talking, can you tell me more about what you mean by fall off a protocol?
Right. So they have a workup for neck or, some evidence of feeding intolerance, however that's defined in your unit. So the feeds are stopped. So they are now kind of off protocol? Do we put them back on the protocol and do make the same?
Or where do we resume them? So I
Where?
think our protocol right now ideally aims to have babies back to up to full enteral feeds by day 10. Right, off TPN, off lines by day 10. That's the ideal scenario. But like Daphna said, sometimes a baby has feeding intolerance scare, and so like, oh, we're holding feed. So now suddenly maybe day 6 goes by, and now we're no longer advancing, and so on and so forth. And then you find yourself resuming feeds, but at a lower rate, and so now you're completely in a different realm. And I feel like these babies then don't have any standardization as to how do they get back on track, like Daphna said, or I think that's interesting. How do we handle these particular stragglers?
I would just say, we struggle with that as well. And I think it depends. We have a higher growth restricted population, I think, than some. We need to publish this. We're working on it. But that is a subset that is just a really, not just prematurity, but then, their physiology is different. And someone needs to research that in addition. But so I feel like they fall off the protocol a lot. I do this a lot with our intestinal failure program. No baby follows the protocol. So, I mean, we just do our best. I know it's hard, like if a baby was 80 per kilo feeds, and maybe you would just fortify and they have a neck scare and they're MPO, but we would just go back to 20 per kilo and probably restart the protocol, which I know has setbacks. Some babies are a little different, but I just think that's how we try to do it. But it is hard because then they're a whole week behind on feeds.
But it's also comforting to hear that other people are doing that, because sometimes I feel like, oh my God, like I'm causing this poor baby is
starting
now
from scratch.
Yeah, exactly.
Yeah. But also, I mean, I think Dana, you can speak to this, but I'm sure I consider you a parental nutrition lipid expert. But you need to make sure you're giving good calories, parentally as well, in order to kind of have that period of MPO, in my opinion.
I think in general also what I picked up from Amy is, in a sense, don't despair for a couple of reasons. Yes, many of us are experiencing that, but back to the benefit, the value of some standardization, most kids get the benefit of that program that you've designed. So that's the key piece. Not all will. It's impossible to have everything go perfectly, but there is still value in all of the reasoning that went into that standardized approach, whether it's parenteral nutrition or feedings, that will get that kid back on track. And usually when people publish on, say, standardized feeding guidelines, it's often the case you'll see, what was the day that kids actually got to full feedings. Right. It's not always right on that mark that the guideline says. No. It can be often after, but still, it's probably sooner than if it were the Wild West and each attending was, making a decision on their own. Because, of course, we all know best in the moment exactly at that hour,
that's right.
Et cetera, et cetera, et cetera.
Well, we were talking, this is a perfect segue, we were talking off air that, we've been focusing a lot on feeding, which obviously is very valuable. And I have this sense that we're not doing our best job at optimizing the TPN that the babies rely on while they're getting there, or on so many of these babies that can't feed for whatever reason. But maybe I know you have a lot to say about how we optimize TPN and lipids.
Yes.
That's right.
How much time do... No.
I would like to
give us the top
think
3 most important things we can do in our TPN.
I think top 3 things. One thing we underappreciate is, on rounds, at least, again, I don't mind airing our dirty laundry in our unit, but
I think it helps all of us when we can.
Therapeutic.
Specifying what the calories are that the child got, or even what you're prescribing in NICUs, ICUs, adult pediatric NICUs. You could comfortably expect that your patient will get fewer calories or less nutrition than you prescribe. So that's a reasonable starting point. But specify the calories. And then the part that I think we don't incorporate enough in our rounds is the appreciation of the balance of the calories, specifically protein calories versus non-protein calories. Because a key piece, especially for the preterm infant, is providing enough non-protein calories so that the baby can use those good protein calories for tissue growth. It's probably more favorable metabolically. And really, I think those are a couple of things that with the parenteral nutrition prescribing don't get enough attention on the day-to-day rounds.
Yeah, lots of total fluid volume talk. Not a lot of total
Yes.
calorie talk. Yeah.
Yeah, I think as long as you're talking about it every day on rounds and making it a priority, and I would throw in, you can't look at day-to-day length gain and head circumference gain, but like really trying to take a look at the growth chart, because sometimes a baby may be up, down, or maybe they're gaining weight, but I mean their length is completely flat. Can I ask a question to Daniel?
Yeah.
Okay. No, I'd love to hear this. No, I know a lot of units. We don't have to get into which lipid we should use, maybe. But
We'll touch on that later.
Or, yeah, in your talk. But my question is, I just want to make sure that if depending on what lipid they're using, they're giving enough essential fatty acids and that, right, and calories as well.
Yes, I will. I do touch on that in my talk. But to be clear, as I phrase it, we have been spoiled. In the U.S., we've been spoiled for decades, because the main go-to IV lipid, which was composed of 100% soybean oil, had just a bunch of essential fatty acids, and we really never had to think about the risk of essential fatty acid deficiency unless we were doing extremes of reducing the dose or withholding lipids entirely. But my take is we've been really spoiled, and now that we have these newer emulsions available in the U.S., they've been available outside the U.S. for a bit longer, people are taking liberties with the dosing, and it has been reported more than a couple times that essential fatty acid deficiency can develop, at least on the biochemical measure. So you're right, we need to be paying more attention if we're using different emulsions and altering the doses.
And I just bring this up because I'm thinking about your preemie that fell off this protocol that's going to be MPO. Sometimes, especially if they're extremely preterm, they have lipid intolerance or they're high triglycerides. So, and then the doses get messed around, and then it's like, oh, wait a minute. We may not be giving them what we think we're giving them. So just a little nuance. Absolutely. I appreciate you answering. Yeah.
Since we're talking about TPN and lipids, you do touch also a little bit about TPN cholestasis. And something I really have not admittedly thought a lot about is the anticipated trajectory of TPN cholestasis recovery, right? We're like, we feel like it's going to recover. We follow the things, they get better. Sometimes we give some other meds, but what should we anticipate? What is a normal expected recovery, and how long is too long that if it's not recovered, we should say, like, we got to think about something else here?
My starting guidance is be patient. The recovery.
That's so hard for me.
It is very hard. It's, again, we're all not alone. We're all having the same experiences, but it is easy for me to comfort our clinical teams in our units. Just be patient. Yeah. It is a slow process, and that's okay. In fact, when you look at curves, trends in these bilirubin levels, you can see little blips of, a peak up when you think you're on the road to recovery. Still, it's okay. Just hang tight. Just it out. And it will take weeks, depending on the infant and the severity, months to get towards recovery. Now, the one piece I really want to emphasize, I hate to be a downer, but there are, I think, enough reports with histologic evidence or liver biopsy samples where we do know that even if the bilirubin level has fallen way low, and we think biochemically, as best we can tell on the unit, the child isn't cholestatic, doesn't always mean that the liver is completely healthy. You can still see fibrosis, indicators of injury on the biopsy specimens. So it's something to think about there. The markers that we have on the unit, definitely valuable. You want them to go low. Yep.
So say we got our baby back on the track for feeding. I really liked on your lecture today, Amy, the survival curves for neck by the amount of mom's own milk. And this is something, we know, but to see it in graphical form, I think was really striking. So maybe you can describe that.
I'm like, those.
I can pull it up for you.
How many slides do you have there? Because I think those are my old slides, but I am happy to talk to it. Oh, goodness. I'm going to have to talk to them and make sure I had way too many slides. I'm just, okay. No. I know that slide well. Yeah. I'm just saying I had to cut. So you're supposed to do one slide a minute. And,
so you may not be talking about that today.
I totally broke that rule. No, I cut my slides. No, but that is one of my favorite graphics. I'm happy to talk to it. But when you said that, I was like, wait a minute.
Is it on my
Okay, so anyways, but hey, more is less. Okay. Sorry, distracted me. You know how it is when you change a talk and you.
That whole 1 minute per slide rule.
I know. Sorry, we digress.
Let's say you are given a 50-minute time period. I've cut slides from 50 slides to 40 slides to 35 slides, and somehow
it still takes the whole time.
Blather on beyond close to the hour. I don't know how that.
I'm
happens.
The opposite.
It's awful.
I'm visual, so I have a lot of graphics and I say little blurbs, but you can please give me feedback after my talk today. So back to this survival curve. No, it's important. So I think it's just to drive home the point that what we have found in some studies is that, the benefits of mother's milk is dose responsive. And for that particular study, it was from the NICHD, babies less than 1,000 grams, I believe, and I think it was like 1,800. It was a large, NRN network look, and they looked in the first 2 weeks of life at neck or survival chance of, you can look at it negative or positive, I guess, neck free and survival. Babies that got more milk did better. Mm-hmm. And so we need to also be careful. That's why I think when we talk about mother's milk, but when we talk about fortification strategies later on, we still need to keep in mind that we don't know the magic cutoff. I mean, we can guess, I can give you a number, but we should always be trying to give as much mother's milk as possible.
Okay.
Does that make sense?
Yes.
Yeah.
And one of my favorite interventions is the oral colostrum care, which you're also going to talk about, maybe.
Yeah. Oh no! I'm definitely talking about that. No, there was
scared Daphna now.
No, it's okay. No. The content's similar. I just had to cut some slides. I turned in 92 and I'm down to 60.
Impressive.
I know that we give. It sounds like. Anyways, I get so distracted. We have renamed it oral immune therapy.
I love that.
In our unit, I don't know if you've done this, but that's a term being used more. But mainly because when we were trying to kind of crowdsource and get our key stakeholders in the NICU, mainly our bedside nurses, what do you think about oral care, et cetera? And some of the barriers, some of them thought we were feeding the babies because it is 0.2 mLs in each cheek, and we, and other team members thought we were feeding, and we're like, no, we're providing therapy, immune therapy. And when you switch the focus that way, it seems like we were a little bit better about following our protocol.
So tell me about I haven't been able to find much about it, but continuing oral immune therapy in babies who are NPO.
Yes.
No, I just sent an email to her.
No, we absolutely need to do it. There's not. We need to publish that. I need some trainees that are eager and want to collect some data. No, really. So for us, it's just been practice creep, but I would say it's good practice creep. I mean, if a baby's not feeding, we still want them to get that oral immune therapy, and we continue it until they're orally feeding, and that's what a lot of the studies did. But I will say there's not an exact study saying should you do it, but anecdotally, and again, we'd have to gather the evidence, but like babies with gastroschisis or some of our intestinal failure babies, I'm convinced, again, have to look at the data, but that it helps them later on. In my mind, it can't hurt them. And I'm going to talk about this in cardiac babies, but the cardiac ICU talk about ICU practice, adopted oral care with chlorhexidine. this is like 14 years ago. So we're trying to introduce breast milk.
Yeah, that sounds bad.
My mucosa hurts right now.
Right. So, but it prevented or decreased ventilator-associated pneumonia in the pediatric and adult population. So why wouldn't you do it in an infant with heart disease if you're on that side of things? And so switching to oral immune therapy, I think I feel better about it,
right.
And I think they do too. So, and it has to be better than sterile water, but it needs to be studied.
Well, tell us more about some of the innovation in nutrition. What can we be looking forward to for our babies?
I'll let you go first. I want to hear about some of your ideas about moms. I think that's fascinating to kind of mom's diet leading to baby.
Sure. I think that one of my long-term goals is, I think that neonatologists have, to a very limited degree, appreciated what mom's nutritional status might mean for the infant, sort of the conditions that the infant has been set up in, and to give one short example, I think that ultimately there's a lot of work to do. We can better understand what the diet quality aspects of diet, not just in the birthing parent, but the parents to create this family unit of diet quality and feeding, what that can do for the health of the infant, for influences on milk composition, but then even thinking long term, again, a limitation of the neonatologist, we get them to discharge and we follow them in clinic, but we're not entrenched in the post-discharge diet quality and nutrition. Right. So I think there's a lot of work to be done there. That's what I'm hoping to tackle.
So your thought is if we can improve the nutrition of the whole family, that will have these long-term benefits because most feeding will be done at home for this kid, not in the NICU.
For all of us, the influence of nutrition and diet on our health, it's a long-term game here. They're definitely, we know this very well, just the milk exposure and risk of neck. There's very much short-term interventions that we can do nutritionally that have a very important influence on health. But then again, there's the rest of the child's life. And there's a big picture there that I think we can, as neonatologists, start to think about.
From an epigenetic standpoint, I think it has a lot of grounds. I guess one of my questions was, are there any discussions about figuring out the optimal way of fortifying feeds? We've talked about calories, and I think there's been a lot of conversation in the literature about how do we fortify babies, what are we using, the promotion of human milk diets, and then there's a lot of factors associated with that, and I'm just wondering if this is something that is an aspect of one of the priorities of your focus group.
Oh, I know you want to take this.
It's complicated, but promising. How about that?
Okay.
I do think innovations are coming. I think just to start this, before we even talk about fortification, you're talking about optimizing the use of mom's milk. I would say our unit's really good, but at some point we have a drop-off during this stay, and we're trying to, I have a fellow working on a project. What are we missing with that family, with the, I think we're missing something. We're not supporting them in a way that they need to be supported, or there's some gap there. And so I think step one before fortification is we've got to have, be able to address that because, donor milk is pasteurized, lower in protein, less immune factors. Babies, mom's milk has enzymes and, a whole list of things, but in regards to digestion and growth, et cetera. Fortification. So, no, the good news is we have newer products, so that's good. Some of our companies are coming out with that, like liquid bovine fortifiers, which we used to not have.
Right.
And they don't displace mom's milk as much. We also have the option of the donor human milk-derived fortifier. And there was actually, I'll just bring it up, there was a recent study, we were expecting it out of Sweden. They called it, I think, the N-Forte study, but they looked at true fortifier difference between donor human milk-derived versus bovine. And their outcomes, it was smaller, but still, a good-sized study, and it was a composite outcome of like sepsis and NAC, et cetera, and they didn't see any difference. But again, it goes back to they have very high breastfeeding rates.
Yeah.
So what do I do in my unit when, despite everything I can do, we still have 40% or lower percent of babies that they might get milk the first 2 weeks of life, but then, the rest of the time they're getting pasteurized donor milk. So I still think I hate to say that, like be that person, more studies are needed, but we got to address the donor milk issue and how to get more mom's milk, and then kind of start layering on the fortifiers. I don't know if that's helpful.
Well, it sounds like the one thing we don't need more data on is mom's own milk good, right?
Right, absolutely, absolutely.
So, yeah, I think still in the community there are people who feel like, okay, well, at least we're giving donor milk.
Yes.
It's equivalent to mom's own milk, and it's really not,
right.
Sadly.
I experienced that in my own institution. I mean, we started using donor milk in 2009, and 5 years in, I was like, wait a minute. Everybody's like, oh, no, we have donor milk.
We have milk.
We don't need moms. I'm like, whoa, let's put the brakes on this.
Yeah, I think the N-Forte was recently published.
Yeah,
I'm looking at that.
It was just recently. I bring it up just because I've had people ask me about my thoughts. And honestly, I haven't done a extremely thorough look at it. I kind of did a quick read.
Yeah, it's supposed to come out in the Lancet. It came out in a different outlet in the meantime.
Oh, that's right. I'm so sorry. It was a preprint.
It's a preprint.
I'm sorry. Okay. Yeah.
Yeah.
Roll the brakes on that one. I mean, yeah. No.
Edit. Cut.
No.
I'm not getting in trouble here.
I know. No.
She
Okay.
speaks for herself.
I do. I'm sorry. No, I do want to be clear to our audience. If something's in preprint, it has not been peer reviewed. So it needs to be peer reviewed before we can further comb through it. There's a little glimpse that's coming.
Yeah.
Okay. Sorry about that.
No.
Thank you.
No worries.
Thank you.
We thank you for all of your expertise so far today. Any other things you want to tell the audience about things they should be looking forward to?
Go.
Looking forward to, I think this is like a bigger view. I really appreciate, we talk about the differences in our units, and I recognize that there's some units that don't have the benefit of investigators, clinician scientists,
Most units,
on the
right?
faculty, and I think I really underappreciated that for a long time until recently, and so one, I feel lucky for our units, but also I can speak for Amy. There's just this neonatal nutrition community that is just wanting to be of help and sharing of information and ideas, and also share, oh yeah, we have the same struggles. And so I think that's just a big piece of this.
Yeah, no, and I think, we're always happy to answer questions. I mean, this is what we do. But also, it's just need to be at conferences like this to bring everyone together in a big database format, be able to look at different variables. I was joking with someone, I need to not joke and be serious. I wish we could add some extra nutrition variables, but to add a module or extra data. There is some, but I just think, I think it's a lot of focus on preemie nutrition, but there's this whole diverse population in our level 4 NICUs that we used to not take care of, and so we need to figure them out too.
Yeah.
And so I'm hoping big consortiums like this and people that are interested in these small populations want to move the bar on nutrition for that.
I like that.
Perfect. Well, thank you both so much for joining us. We had the pleasure of previewing your slides, but we're going to look forward to hearing your talks later today. Thanks so much.
Awesome.
Thank you very much.
Thank you so much for having us.